That's a long story. I've been in private practice for almost 35 years. I do bariatrics exclusively now, but I've always been involved in bariatric surgery since my residency and early years in private practice. I spent the first 10 years really doing trauma surgery, and I did a fellowship at a major trauma center in Baltimore. That was my love, but so much of what we did in the ICU, patients severely traumatized, or other very severe illnesses that were part of my practice, was nutritional based. And so the use of nutrition in a positive way to save lives after severe traumatic injuries or illnesses was a key focus of mine, and it sort of led me into what I do now, because it's all the same. Weight loss involves knowledge of nutrition and the ability to convey that to our patients so they can utilize it. So I think that my overall experience has been broad as a general surgeon, but I think more than anything, it's been my interest and my focus on surgical nutrition over the years that I think has put us in a unique position to be able to care for patients who have weight issues and need to lose weight. When somebody comes to our practice in need of weight loss, the first thing I do is not talk to them about surgery. I want to verify, have they been through all the things that normally people go through to try to lose weight? The answer is usually yes, but I want to verify that. Next, I want to go through a discussion of the individual issues that somebody's dealing with, not just the excess weight and not being able to wear the size or the clothes they want, but more than us as a surgical practice are focusing on the comorbidities associated with obesity. Number one is diabetes. Number two is hypertension. And hypertension, diabetes alone explains the heart disease risk and stroke risk that come at much elevated levels of being obese for many years. We want to establish what it is that a patient is there for. Delve into the history. Of course, go into their complete medical history. There'll be a lot of tests, a lot of things sometimes to cover for insurance purposes or for governmental purposes or just our own program and its pathways of excellence. Getting to bariatric surgery is a long and complicated process in some patients because of the demands placed upon patients and us for insurance approvals. Sometimes insurance will deny, or patients do not have insurance for this sort of therapy. So we will discuss with patients other options of being able to afford it. We have financing plans. It's doable. We will work with patients to make that happen. That is an excellent question, because we know everybody loses weight, with rare exception, with the operations. So we accept that, and patients accept it and expect it. More importantly, though, is what happens afterwards. We expect patients to lose weight, and most do. However, getting to a normal weight and maintaining the weight, that's the long-term goal. So we do at BayChoice provide very careful follow-up over time, at least 5 years, according to our national society. We'd like to follow you for a lifetime to ensure that not only are you able to get to your normal weight, but you're able to maintain and, more importantly, have optimum nutritional status during all that and at the end, and for a lifetime. That's a very good question. That's really a very important question. Getting patients to surgery is difficult enough as it is, with insurance approvals and all the tests and various diagnostic studies that we have to do. We, of course, talk and explain and coach with our dietitians and our practitioners, but getting to surgery is the first step, and our resources will allow for, in all likelihood, approval if your insurance does cover it. If not, out-of-pocket expense, we will still have some diagnostic tests, of course, but it's a little bit more streamlined for those who are not having to go through all the insurance hassles. There are 3 operations that we offer. Adjustable gastric banding has been popular in the past, and I've done thousands, but I don't recommend them anymore. I think patients have a better option, and that would be a gastric sleeve. Gastric sleeve does much of the same thing that a lap band does, meaning create a small restricted pouch. But more than that, removal of the dome of the stomach, or the fundus of the stomach, which contains the cells that produce ghrelin, the hunger hormone, is essential in reduction of hunger. So the combination of hunger reduction and a restricted pouch generally leads to very, very predictable weight loss and requires no adjustment, as does a lap band, and that's the key difference. Patients with lap bands also have swallowing problems, to the point that we're removing many patients who've had lap bands and converting them to gastric sleeves. So gastric sleeve has become the real workhorse. Probably 9 out of 10 patients in our practice, and most bariatric practices, are undergoing gastric sleeve. The weight loss expectation with a gastric sleeve is on par with a gastric bypass, without the risks of long-term malnutrition, which is always present in a gastric bypass. Gastric bypass, we can't forget it, however. It's a very good operation, it has a specific application. When we see patients who are diabetic to the point that they're requiring insulin, our first reaction is to offer a gastric bypass, because gastric bypass is considered the definitive cure for diabetes. However, many patients don't want to endure the added risks long-term of gastric bypass, that being nutritional deficiencies, namely micronutrient, vitamin, minerals. Patients lose their weight, but we don't want weight loss with poor nutrition. We offer whatever operation is that makes sense for a patient. We help to arrive to a consensual decision between us and our patient, but certainly we want to accommodate our patients' needs and desires and expectations as best we can.